specifically the pass marks for the National Clinical Coding Qualification, the NCCQ.
Oh, right. Yeah, that.
And I honestly think I'd fail it in like 10 minutes. I mean, the practical exam, paper 1, requires a 90% to pass. 90%.
It's wild. It really is.
That is tighter than the written theory requirements for airline pilots.
It sounds completely hyperbolic, but it's accurate.
Yeah.
The NCCQ is, well, it's arguably one of the most brutal professional certifications in the UK.
Right.
And it has to be, because these aren't just administrators filing paperwork in a back room. They are the invisible engine of the NHS.
Our mission today is really to unpack that because, clinical coding sounds like basic data entry until you realize what they're actually doing.
Exactly.
They are translating human pain complex surgeries, messy doctor's notes, tragic diagnoses into a standardized digital language.
And if they get that translation wrong, the consequences are massive. We aren't just talking about a bad grade on a test. We're talking about hospital funding.
Right, because accuracy is money.
Precisely. If a coder has a 10% error rate out in the real world, they could be costing a hospital millions of pounds in lost revenue because a procedure just wasn't billed correctly to the government.
Or they skew the data entirely.
Yes. Epidemiological research relies on this. If you code a cancer cluster incorrectly, public health resources go to the wrong town.
Wow. Okay, so let's look at the pressure cooker paper 1. The sources describe this as a 3-hour open book exam, which usually implies it's easy, but...
But here it means frantic page turning.
Yeah.
It simulates a real chaotic day in a coding department. You have your manuals, the ICD-10 for diagnoses, and the OPCS-4 for procedures, and you're just against the clock.
And you have these quick-fire sections.
Right, where speed is everything, followed by incredibly complex case studies like neurosurgery or oncology,
where a doctor might write 3 pages of dense notes, and the coder has to extract the definitive diagnosis from that wall of text.
Which leads us perfectly into the theory exam, paper 2.
The closed book 1, where the pass mark drops to 70%, but it's all medical science.
Because you cannot code what you don't understand.
I was really struck by the specificity here. It's not just knowing that Arthur means joint. It's way deeper. Like, if a patient has pneumonia, a coder needs to know if the organism is viral or bacterial.
It completely changes the code classification. They need to look at a discharge summary, see consolidation of the lung, and understand the underlying pathology.
And know their anatomy cold.
Oh, absolutely.
Yeah.
Confuse the radius for the ulna in a fracture case,
Yeah.
and you falsified the medical record.
Which explains why spelling is such a sticking point. I saw that a single character typo in the theory exam
changes the diagnosis entirely. Yes. In this language, one digit is the difference between a closed fracture and an open fracture.
Or a primary malignancy versus a secondary one. The difference in treatment costs between those two things is astronomical.
Not to mention the patient reality. And they also need to understand statistics like standard deviation for healthcare analytics.
It seems like you need to be a linguist, a biologist, and a statistician all at once. It's getting harder right now. It's February 2026, and the OPCS 4.11 update goes live in April.
This is a huge shift. Over 600 new codes are dropping just to keep up with modern tech.
Things like leadless cardiac pacemaker systems.
And subretinal injections. The codebooks have to expand as fast as the surgery techniques do.
And this highlights the UK's specific translation challenge. They use the SNOME-NCT integration, right? The massive clinical dictionary.
Right. SNOMED allows a doctor to be incredibly specific, say, fracture of left distal radius with displacement. But the coder has to map that granular term to a broader billing code.
And that mapping requires a human brain, which is a huge divergence from the US right now.
Massive. The U.S. system is driven by insurance billing, so speed and maximizing claims are the priority.
Which AI is great at.
Exactly. But the UK's human-in-the-loop approach prioritizes the integrity of the long-term health record. They want a human to verify the clinical truth.
So for the people passing this brutal exam, gaining that Accredited Clinical Coder or ACC status is a big deal.
It's a huge lever. It triggers an immediate jump up the agenda for change ladder, which, for our international listeners, is the standardized pay scale across the NHS.
It turns a job into a real career, guaranteed pay rise.
It really does. They secure the integrity of the nation's health data.
It's a fascinating corner of healthcare. So I'll leave you with this provocative thought. Next time you visit a hospital, remember that your entire medical journey, your pain, your recovery, is eventually translated into a code by a human who had to memorize the biology behind it just to ensure the lights stay on.
It definitely makes you appreciate the discharge letter a bit more.
Absolutely. Thanks for joining us on this